Welcome to the 8-Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. Welcome back to the 8-Minute Rule. We've got Mark and Drew here again, and actually we've got a treat. Mark's got a case for us that we're going to talk through. So go ahead, Mark.
All right, so this has been a little while now, but the gist of it was I had a mid-50-year-old male come in. Chief complaint was testicular pain, and it was unilateral. I can't remember which side, but chief complaint was testicular pain, and he did have a little bit of flank pain. Those were his two problem areas. When I was going through the subjective, he was a golfer and was having trouble with his golf swing, and he had stopped lifting a lot of weights because it was also hurting him, and he was also afraid, particularly because of the testicular pain. So I'm going through the subjective with this guy, and at one point he's told me he had spent like $6,000 or $7,000 on testing. It was all this blood work, all the images, all of the things. Nothing had come back. So he's coming to me, he was looking for answers, he was trying to get something out of it. And so I finished the subjective, and I was like, man, this guy has testicular cancer. There's nothing I'm going to be able to do for this guy. I was very much novice as far as testicular pain was, and so I just didn't know what really to do. But I knew that even if he had testicular pain or cancer, that I was going to have to go in and do an objective exam to rule things down and make sure that I was not finding like true musculoskeletal findings. And so I went back in, and I really kind of had an aha moment where like I was doing a segmental exam on his low back, and I think it was a UPA, so unilateral PA, right around the TLJ, and I pressed in, and he was like, oh, that's weird. That creates my testicular pain. And I was like, oh my gosh. First of all, I was thankful because I was like, oh, I have something. But that was the moment where I was like, well, I'm glad I did an objective exam. I'm glad I didn't run off because of the testicular pain, but I was definitely concerned. In hindsight, I'm thinking like I probably shouldn't have been as concerned as I was, but I was very much in my head at that moment in time, for sure.
Yeah, I think it's a really good case, and I like your thought process around you saw something that was concerning, and when we're looking at different options coming into this, it's going to be, are we going to treat it? Are we going to treat and refer, or are we going to straight refer? And as you said, you have the option there of, oh my goodness, this is something that I want to get somebody else in on, potentially referring. I think the first thought that comes to mind for me as you're digging through, and again, I know it's a quick blurb of his history, but he's had a lot of testing, right? So he's had blood work, he's had a lot of, some imaging as well too. While we never want to assume that everything's been covered. We want to be super thorough. We want to make sure that we have had some things covered. We also don't want to be the one that's either delaying what could be helpful care or necessitating further imaging that didn't necessarily need to be done. And so, I think as you've done, that even if you kind of have in your mind that you're going to refer them, doing a valuable objective is huge here, because we do tend to see those weird mange syndromes and other stuff like you found that can show to us. I think definitely being able to look and see what objective measures can potentially tie into it. And I think the other thought for me is between I always want to go towards what has been done, and if I am going to refer, what typically is the next step. I don't want to try to step outside of my scope, but I also want to make sure if I'm referring to somebody that has already seen it and had a pretty good idea that this is stable and needs some treatment as well too. Those are kind of the first things that I want to look at. So, Drew, what about you? Got any thoughts on that?
A few. I think it definitely shows the importance of making sure we're doing a thorough examination and having a good hypothesis list. So what are the other things? What are the competing hypotheses that this could be when you're thinking, oh, this guy has testicular cancer? What else could it be? And vice versa, when someone comes in with, your traditional low back pain or whatever it is, what are the other things it could be? And making sure you're consistently thinking about that, right? We are a doctoring profession. We have direct access. Those need to be at the forefront of our mind. The other thought I have is that this gives us, I think, a good opportunity to work with the rest of the medical community of, hey, the patient's coming in and saying all these things. Oftentimes we maybe don't have all this information exactly. Fortunately, Mark found that there was some sort of mechanical thing that reproduced it. I'm assuming he got significantly better with treatment. But even if it wasn't and you're saying, okay, I need to send this guy back out for potential referral, making that connection with the provider and, one, showing where we belong in the medical field, that we can be primary care providers, that we did an objective exam, we have this information. Here's what I'm seeing, here's what the patient told me. Do I need to be concerned about this? Is this something you have considered or ruled out already? I've had several providers be extremely thankful of, yes, actually we did do this. The patient didn't have it. I didn't see it in the notes, or they didn't send it. Maybe they were direct referral. And they can come back and say, well, here's what we have done and what we have ruled out, just to help with your clinical decision making. So that can be a great opportunity and help with your relationship, show where we're at, where we could be in the medical community, and help calm any fears with that patient, because he might not have understood that they did all these other testing things and here's specifically what it meant, and you can be the person to help educate them around that, and then they'll see you again as a little bit more of a medical expert in our field and musculoskeletal expert.
Yeah, I love that. I think, as you mentioned, Drew, one of the biggest pearls from that to me is creating that relationship with the provider. You want to be able to have a provider that trusts you, communicate your evaluation. We know as clinicians that we're giving a very, very thorough evaluation, much more thorough than most people in the medical field are given. And so I think being able to communicate what it is that you gathered out of that, as opposed to, hey, yep, something's wrong, and sending it back, whether it's primary care, who, again, primary care is looking for where it needs to go, not necessarily just that something's wrong. So I think that a great way to build a relationship, great way to also establish kind of our position in the medical field as well too. Quick thoughts here too, Mark and Drew. How long are you going to put up with this? You got these symptoms, you feel like you got a good direction to go here. Let's say a session or 2 or 3 in, you're not really seeing a consistent change, consistent improvement. How long are you going to give before you're starting to change your plan there?
I mean, for me, it can be pretty quick, especially if I'm coming out of the initial evaluation. Maybe I haven't been able to fully rule down a more sinister condition or something that would require a referral, and I'm just treating this patient. Like, let's say I give this person a directional preference exercise, and it makes no difference on their symptoms at all, meaning no better, no worse. It's starting to sound a little bit less mechanical to me. I may start to explore referrals much quicker in a situation like that.
Yeah, I was going to say it will depend on what those competing hypotheses are and how significant, or how quickly you need to get them to someone else. The other thing I would say is consider referrals within your clinic, within clinicians, and seek the advice of mentors or other people who are in your field. Like, I've asked Mark already about, hey, I've got this. What do you think about X, Y, or Z? Because that can help, again, with your decision making, help potentially look at hypotheses you didn't consider and hopefully get that patient better. So, if you're getting another person who's confirming, no, you probably need to send this out, then maybe you should think even harder about it. But I would say even considering a referral within PT to someone else to get eyes on it as well.
Great thoughts. Definitely plug there. Your local pelvic therapist, if in clinic or around, could be a really good resource here for some of these tricky cases that they see a lot of. So, all right, as always, good stuff, guys. Till next time.